Hello everyone, my name is Lorraine Carugda and I will be presenting today the case of my patient who has hypothyroidism. So the patient date of visit in the clinic was last May 24, 2024, and her chief complaints is that the patient verbalized, "I can't explain the feeling that I am always tired and I am gaining weight despite not eating much for a few months now." Her HPI includes patient is a 44-year-old Hispanic female, presents to the clinic today for evaluation of laboratory results. She was first seen a month ago with complaints of unexplained tiredness all throughout the day for several months now without much to do. The patient reports weight gain of 10 pounds over 4 months despite regular exercise and poor appetite. Excuse me. The patient reports she always feels cold by wanting to wear a sweater despite of a warm weather for spring and summer. The patient reports regular menstruation with no issues. For her subjective data, the patient reports no past medical history. The patient reports no surgical history. She reports seasonal allergies, and she reports she is taking multivitamins 3 times a week. For her family history, her father is 78-year-old living, was prostate cancer. Her mother is 76-year-old living, was a history of high blood pressure. Her daughter is 18-year-old with no known medical history. Her aunt on maternal side is 70-year-old living, has a goiter, and her siblings and grandparents of a known medical history. For her social history, the patient is married with one daughter of 18-year-old. She lives in a single family house. She reports walking for 20 to 30 minutes 3 times a week as a form of her exercise. Her usual diet includes tea in the morning and bread, rice and fish or chicken for lunch, and bread for dinner. The patient works in a local pharmacy and she reports being sexually active with no history of STIs. She denies tobacco use and alcohol consumption, and she reports no illicit drug use. She reports her last menstrual period of last April 30, 2024, and she denies feelings of anxiety and depression. For the review of systems, the patient reports fatigue, weight gain of 10 pounds over 4 months, and intolerance to cold. The patient denies hoarseness of voice, sore throat, and dysphagia. The patient denies shortness of breath and wheezing. The patient denies chest pain and palpitations. The patient reports constipation with her last bowel movement of 5 days ago. The patient denies any joint pain and weakness, and she denies feelings of depression and anxiety. For her objective data, her vital signs are normal. Her blood pressure is 110/68. Her heart rate is 70. Her temperature is 97 degrees Fahrenheit. Her respiratory rate of 13. Her O2 sat is 96% in room air. And she weighs 170 pounds. And she is 5 feet 4 inches tall, which brings to her BMI of 29, which she is classified as overweight. For her physical findings, so she is 44-year-old Hispanic female, dressed in sweater and leggings in the summer season. Patient seemed tired with no acute distress. Her head is normocephalic, and dry hair is being noted. For throat and mouth, the buccal mucosa is pink, moist, no lesions is present, gag reflex is present, uvula is in midline, no hoarseness of voice is noted, and no gum bleeding noted. Her trachea is in midline, lymph nodes are non-palpable, thyroid non-tender, and then enlarged bilaterally with no palpable nodes. Her lungs are clear bilaterally. Her heart rate is regular rate and rhythm, no murmurs S1 and S2. Her abdomen is round, hypoactive bowel sounds are noted on all four quadrants. Her skin is dry and scaly with no rashes and no lesions present. Normal gait is observed, muscle strength is 5/5 with intact sensation, and deep tendon reflexes are all normal. Her significant findings in a laboratory with her laboratory results include her TSH is elevated of 21.8, her free T4 is low of 0.85, her lipid panel, cholesterol, HDL, and triglycerides LDL are all normal. Her vitamin D3 level is 13, which is low, and her other laboratory results are within normal range, such as her CBC, her hematocrit, and her hemoglobin. Her BUN and creatinine, ALT, and AST are all normal. This brings up to her working diagnosis of hypothyroidism of E039. So, because of her laboratory results of TSH is elevated and her free T4 is low, so and also her physical findings shows that she has weight gain, she's complaining of fatigue, she has constipation, she has dry skin and dry hair. So this brings all together to her working diagnosis as hypothyroidism. So hypothyroidism, according to Hollier 2021, so it is a reduction in the free circulating thyroid hormone, particularly the T4. So the risk factors for this patient that she has hypothyroidism is that of her increasing age, and she also has a family history of goiter from her maternal side, which is her aunt. Also, the incidence of hypothyroidism is common in females than in males, and it is more prevalent above 40 years old and above. So for her confirmatory test is her lab results of her TSH, which is elevated, and her free T4 is low. That brings about that she has hypothyroidism. So as I have said, her physical findings or physical assessment during examination is that she has dry skin, dry hair, hypoactive bowel sounds, and the patient reports weight gain, fatigue, and constipation, and dry skin, hypoactive bowel sounds, and she as being overweight of a BMI of 29, which brings all together as she has hypothyroidism. Other assessment findings include vitamin D deficiency, which is seen on her laboratory results of 13, which is low, and her BMI is 29, which she is classified as overweight. So according to American Family Physician 2021, these are the guidelines or the clinical guidelines for hypothyroidism. So hypothyroidism is classified into three. So we have the primary hypothyroidism, the subclinical hypothyroidism, and the Hashimoto's hypothyroidism. In primary hypothyroidism, it is being confirmed through the laboratory results of the TSH, which is above the normal range, and the free T4 is low. For the subclinical hypothyroidism, the TSH is above the normal range and the T4 is within the normal range. For the Hashimoto's hypothyroidism, the TSH is above the normal range and the T4 is low, which is the same as the primary hypothyroidism, but an add-on of a laboratory results with a positive anti-TPO antibody. So with this, the patient is classified as a primary hypothyroidism because there is no laboratory result yet of a anti-TPO antibody. So with this, the clinical guidelines for the treatment for hypothyroidism is with the use of a monotherapy medication, which is known as the L-thyroxine or levothyroxine. So for in healthy young adults, levothyroxine is being given for as follows. So 1.6 micrograms per kilogram per day. And then in 60 years old and above, 12.5 to 50 micrograms per day, and is increased by 12.5 mcg every 6 to 8 weeks with the signs and symptoms monitored. And for patients who have cardiac disease, levothyroxine is being started in a low dose of 25 micrograms daily. So with this patient, she belongs in this category in healthy young adults, which she is going to be prescribed levothyroxine to be followed as 1.6 micrograms per kilogram per day of levothyroxine. So for the red flags of the patient is having weight gain of 10 pounds in 4 months. She also reports unexplained fatigue. She reports constipation. She has dry skin upon physical exam. She reports a family history where her aunt has a goiter. She's female, wherein hypothyroidism is more prevalent in females and for 40 years old and above. And she also has enlarged goiter. For the red flags for this disease condition. So it could lead to, or it could cause mixed edema crisis, wherein the causes of mixed edema crisis is that, or are, inadequate dosage of thyroid hormone, interruption of treatment, or acute illness such as sepsis. So these are all the causes that could lead to mixed edema crisis. And the clinical manifestations for mixed edema crisis includes hypothermia, seizures, fluid retention, and arrhythmias, according to Patil, among and all others 2024. So mixed edema crisis can also lead to mixed edema coma, which is also a red flag of this disease condition, wherein mixed edema coma is known as a medical emergency, which is a severe form of hypothyroidism. For other tests to be performed to the client that would be helpful in ruling out any other diagnoses are the use of a PHQ-9 questionnaire and an add-on laboratory test for anti-TPO or thyroid peroxidase antibody. Why PHQ-9 questionnaire? Because one of the questions in the PHQ-9 questionnaire asks about if the person or the client has a feeling of tiredness or a little too energy, how frequent is that, just to rule out if the patient has depression or not. So the anti-TPO antibody could also be helpful in ruling out Hashimoto's hypothyroidism, because in Hashimoto's hypothyroidism, the TSH is elevated and T4, the free T4 is low. So these are all essentials just to rule out any other diagnoses that could be helpful in our client in the case presented. For the treatment plan for this patient is that levothyroxine is being prescribed of 100 micrograms, 1 tab by mouth daily, to be taken in the morning. For non-pharmacological intervention or plan, to advise the client to consume high fiber diet to prevent constipation, which she complains of constipation, and to check her annual lipid level assessment. This is because that thyroid hormones are also responsible for metabolizing, or for the metabolism of fats in the body. So, and also increased lipid results or laboratory results are more common to hypothyroidism. It's because that they are less thyroid hormone, which are responsible in the metabolism of lipid in the body. So it's important just to check, so that to provide the right treatment for the client. For education, so lifelong therapy for hormone replacement, and the patient needs to report the signs of toxicity such as tremors, palpitations. They need to report it to the provider immediately. So levothyroxine should be taken on an empty stomach. And then for the diagnostic and to be performed as an add-on would be the TPO, just to rule out autoimmune etiology. So no referral needed at this time. And for the follow-up plan, just to measure the TSH after the patient has been on levothyroxine for 6 weeks, and every 6 to 8 weeks until at the goal, then annually unless symptomatic. So this is according to Hollier of 2021. For the plan for the vitamin deficiency, E55.9 is to prescribe 5,001 capsule of vitamin D as a supplement daily, and to encourage the client to eat high in vitamin D foods such as yogurt. For overweight, E66.3 is to encourage the patient to consume more nutritious foods, less in calorie and high in protein, and to encourage the client to exercise 20 to 30 minutes 3 times a week, which the patient already has been doing. For the differentials, so I present anemia and depression, and heart failure and kidney disease. So anemia D64.9. So the classical symptoms or the classic symptoms of anemia includes fatigue, weakness, tiredness, and shortness of breath, wherein the patient complains of fatigue. So it could be a sign of anemia, but anemia is being ruled out in this case because although the patient may present some of these clinical manifestations such as fatigue, the patient's RBCs, hemoglobin levels, and hematocrit levels are within normal range. So therefore, anemia is ruled out at this time. Another is depression, F32.9. So although PHQ-9 questionnaire was not used on this case, this the depression is ruled out because the patient denies any signs of or feelings of depression or anxiety, and hypothyroidism is the working diagnosis for this because of the confirmatory laboratory results of increased TSH and low free T4. Another is the heart failure and kidney disease. Why? Because heart failure and kidney disease, the clinical manifestations, one of the clinical manifestations for this disease condition is weight gain. So for heart failure and kidney disease, the weight gain is usually sudden. So while the patient's weight gain is gradual. So the patient's was gaining weight for 10 pounds in 4 months. So with heart failure and kidney disease, the weight gain is more of like sudden compared to gradual weight gain. Also, kidney disease is ruled out at this time because the patient's BUN and creatinine is within normal range. So therefore, this diagnosis is ruled out. These are all the questions for my case. So it's 5 items, and the last would be my reference. So that's all for today. Thank you very much and have a great day.